yeah, above the consolidation, right? So there will be definitely up to the apex of the lung will be involved, the consolidation, right? Like that. So that's one way of differentiating a thymus from a right upper lobe pneumonia, right? Because it is going up like that, and then it's a collapse. It should be convex border like that, and right middle lobe pneumonia, you can't see the right heart border clearly, right? Right heart border will be obscured, and right lower lobe pneumonia there will be diaphragmatic surface being obscured. Right? Okay, I think we did that day, but there's some connection problems, so I won't highlight that. Right, so these are three different type of lobe pneumonia you get, and bronchopneumonia means there is fluffy shadows scattered throughout the lung field, not a homogeneous area where the consolidations are confined to a particular anatomical demarcated area of the lung. Right, so that's the difference between lobe pneumonia and bronchopneumonia. This is one students get wrong most of the time. So lobe pneumonia, it is a area clearly clearly involved anatomical demarcated area, but the margins may not be clear. Right here in consolidation, margins may not be clear, whereas in collapse, the margins will be clear cut. Right, as you can see, in all these the margins are not clear cut. Right. So we start from today's one. So this is the 4-year-old boy who had coryzal symptoms during the daytime and woke up early morning with difficulty in breathing. What is the diagnosis? You can contribute. You can answer the question, right? Anyone want to have a try? What is the diagnosis?
Steeple sign in groups.
Yeah, this is the steeple sign, which is signed in group. Good. So what happens is there is the tracheal column is there like that. Actually, come to end. So that is around the glottis area. This look like a that steeple of a church. Like a kota wage. Some people call it pencil sign as well, right? So it's characteristic history. A child around it can be around somewhere around any age from 6 months to 12 years, like you get coryzal symptoms during daytime, and then child go to sleep usually without any much problem, but wakes up around 3 o'clock, 4 o'clock in the morning with acute onset breathing difficulty and loud stridor, right? Very loud stridor where you can hear it from the outside the room as well. Child's inside the room, very loud stridor. But generally, the respiratory difficulty is disproportionate to the stridor. Stridor is very loud, but child may be not that ill. Can be ill, but commonly child is not that ill, and there can be recessions due to upper airway obstruction, and child will not have swallowing difficulty, right? So the only breathing difficulty, and the common etiology is para-influenza virus, but other viruses can cause it. Right? Even influenza virus can cause it, but commonest one is the para-influenza virus, and main treatment is steroids. Either you can give it as a oral dexamethasone if child can swallow it, or you can give it as a nebulization of budesonide. Budesonide nebulization, either one of them is enough usually. Child can't swallow, if you can't make child to get medicine down, you can nebulize it budesonide. That will rapidly improve the symptoms. But important thing is this is not pathognomonic of croup. Even some normal children, if you do routine X-ray, you might find this sign, right? So you from this sign alone, you can't make a diagnosis. It's actually a supportive diagnosis, and generally we don't do chest X-rays to diagnose croup. So remember that, right? So unless you are suspecting and underlying some other abnormality as well, we don't do chest X-rays to diagnose croup. acute laryngotracheal bronchitis. The group is a general term, acute laryngotracheal bronchitis. We don't do routine X-rays for this condition. But if your hospital is in any other thing, then you might do it, right? So it's not the essential thing. It's a clinical diagnosis generally, right? Any questions about that? You can clarify any doubts you have about this condition while we go on, right? Any questions? Then we move on downwards. So this is a X-ray from a 3-year-old girl having high fever and breathing difficulty, and she has an anaphylactic reaction following 2 months vaccination. So, what is the diagnosis?
Thumb sign in acute epiglottitis.
Good. The thumb sign in acute epiglottitis, right? So this is the airway, trachea. This is the pharynx, and this is the epiglottis, right? So the epiglottis is swollen and edematous and inflamed. So it looks like a thumbprint appearance, thumb thumb appearance, and cause acute airway anaphylactic reaction in the history. Can anybody think of the relationship between this history of anaphylactic reaction at 2 months and epiglottitis?
So the cause is hemophilus influenza B. So the in 2 months of
Sorry. Yeah. Go on.
so the vaccination in 2 months, which is given for pentavalent, is not given due to the anaphylactic reactions.
Right. Good. So that's what happened. So if you ask this mother will tell all the vaccines were given in correct time, but then this child would not have got the Haemophilus influenza vaccine. That is because child had anaphylactic reaction during 2nd month, right? So at 4 months and 6 months, child would have got DT vaccine instead of pentavalent. And can you give hexavalent if there is anaphylaxis? Hexavalent can we give it? If child develop a reaction to pentavalent, we give hexavalent, which contain the acellular pertussis vaccine. Can you give it? If there's anaphylaxis, you can't give in hexavalent even, right? So if there is a acute encephalitis picture, encephalopathy, acute encephalopathy, or anaphylaxis following pentavalent vaccine, you can't even give hexavalent vaccine, right? For other reactions, you can give hexavalent vaccine instead of pentavalent vaccine. So this child who had anaphylaxis at 2 months would not have had any Haemophilus vaccine unless given separately as a monovalent one. It's not available now freely. So this child would not got the Haemophilus vaccination. So is more prone to develop epiglottitis because the main pathogen for epiglottitis is Haemophilus influenzae. But nowadays we don't see epiglottitis that much because of the routine vaccination of pentavalent vaccine. And because of that, the most common thing that we see now, acute airway obstruction with stridor with ill child, is acute bacterial tracheitis, right? So due to staphylococci, you can get similar picture with very ill sick child with upper airway obstruction and stridor. But characteristic thing in that will be barking cough. A child with tracheitis will have barking cough, whereas child with epiglottitis might not have that much of cough because can't cough because of the laryngeal obstruction. And this again, we don't do routine chest X-rays to diagnose acute epiglottitis, right? So this again done for some other reason, but not to diagnose epiglottitis. Epiglottitis again is a clinical diagnosis and what the most characteristic feature in epiglottitis. Compared to the group also acute airway obstruction with stridor. Epiglottitis also acute airway obstruction with stridor. What is the difference between the two? Main differences.
The child will be septic, sir.
Yeah, child is very ill and septic, very high fever in a child with epiglottitis, whereas a group child will not be that ill. It otherwise all right most of the time. Low grade fever and child would have them coryzal symptoms, and child will not have any. What the other main difference is? Swallowing difficulty in group, right? But in epiglottitis, there's severe inflammation around the epiglottitis, the child can't swallow. So there will be drooling of saliva. And drooling of saliva, child will be maintaining the stooping position and will not like to even move. Because fear of airway obstruction, child will remain still. Whereas child with epiglottitis, laryngotracheal bronchitis, usually will be even playing sometimes, unless this is very severe, right? So drooling of saliva, high fever, ill child, and stridor. What is the difference in stridor between epiglottitis and group? Is there a difference in the stridor? Can you differentiate it from stridor? What type of stridor you get in epiglottitis?
It's an inspiratory stridor.
Inspirated by definition, stridor is inspirator, right? Very rare you get one or two countries that expirated stridor. Both are is stridor. Generally, when you call stridor, it is an inspirated noise, right? So both are inspiratory. Going in. Not common to have expirated stridor anyhow. The main difference in the stridor.
So soft in epiglottitis and cause stridor in group.
Yeah, it's good. So in group, it is very loud and sharp noise, right? Very, very loud. You can hear from far away. Whereas in epiglottitis, it is muffled, soft stridor, right? Muffled stridor might not be audible few feet away even, right? So that's one important thing. Very loud stridor more likely to be a epiglottitis group than epiglottitis, right? So soft muffled stridor is what you get in epiglottitis. So if you see a child like this, what is the most important first step in the management? Any best of 5 question? What's the first thing you have to do?
You have to secure the airways.
You have to secure the airway. Yeah, that's the most important thing, right? Secure the airway. We have to give IV antibiotics like something like third generation cephalosporin. But even cannulation can be tricky because any intervention, any disturbance to the child can induce acute laryngospasms and cause complete airway obstruction and death, right? So until you secure the airway, you don't do anything. You don't disturb the child. Let the child sit on the mother's lap. You can start some oxygen and again ask the mother to hold it without disturbing the child. So just try to strap the mask on the face. That might also induce laryngospasm. So don't induce disturb the child. Leave him as much calm as possible. Get the ENT surgeon, anesthetist, pediatrician. Everybody is a medical emergency, and everybody should be there. And under anesthetic should attempt the intubation. And while ENT surgeon is ready with the tracheostomy tube, right? So if the because don't examine the throat, even just trying to examine the throat can cause laryngospasms. So you attempt intubation with all the precautions taken to do a tracheostomy in case child go into airway obstruction. So once you secure the airway, you can go for IV antibiotics, right? Okay. Right. So shall we move on then? Okay. Any questions about that? Right. This is the X-ray from a 6-year-old admitted with respiratory distress. What is the most significant feature in this X-ray? Can anybody think? What is the most characteristic abnormal change you see in this X-ray?
So are there any additions with the
Not really. Not really. Don't think too much. It's a straightforward thing. Look at also respiratory distress. This is asthma actually, right? This is a child with asthma. This is what you'll get in child with asthma. So there is hyperinflation. That's all you can see. And actually the bronchoalveolar markings will be less peripherally. Bronchoalveolar markings are less because of the hyperinflation. Diaphragms are fattened, heart is more elongated, right? So and there's no evidence of consolidation. May pain may scapula, may margin, may pain, right? So there's no consolidation, there's no bronchopneumonia, right? So it is what you see in asthma, right? So why you get this pattern? Why do you get hyperinflation in asthma?
due to the due to the mucus production, it causes obstruction of the airways, causing that valve effect and causes air trapping inside the lungs. And
right. Good. In a way, it's right. Right. Now, what happens is, now, what is the main problem in asthma? Inspiration, expiration.
in expiration, sir.
Expiration. The main problem is expiration. Expiration difficulty. There's airway obstruction there, right? So there's airway obstruction due to mucus production, right? So generally, inspiration is active and expiration is passive, right? So air has to go out during expiration passively. Right? In asthmatics, because of the airway obstruction, expiration become active. You have to force it out, right? So the air had to go out by passive passage. But because of the obstruction, air can't go out like that. So you will make it forceful. So even if you forcefully try to expirate, when you apply pressure on the alveoli from outside by forced expiration, right? So some air will go out with the force effect, force expiration. But whatever pressure you are going to apply, will apply on the small bronchioles as well. Right? What's the difference between these small alveoli and large small bronchioles and large bronchioles? Bronchus and bronchioles?
Lack
Just
of cartilage support.
yeah, because cartilage. They don't have cartilage, and so what will happen? What can happen? They can collapse, right? Because they can collapse. Because they are not supported by cartilages. So what happens when you apply too much of pressure to get rid of this air trapped inside the alveoli, that pressure will apply on the bronchioles as well, terminal bronchioles, respiratory bronchioles, and they will close. Right? So this you can't apply this pressure only to the alveoli. No? So if pressure applying on the bronchioles, it causes the bronchial obstruction. Then what happens? Whatever pressure you apply there, it's not going to expel the air because the airway is shut down. Right? So after a particular point, you can't get this air out of the lungs. Right? That leads to air trapping inside the alveoli, increasing the functional residual volume. Right? So that's what happened in asthma, both in asthma and bronchiolitis. So both in bronchial and asthma, this is the mechanism of applied to the bronchioles as well. So bronchial shut down, right? Clear? Harida?
Yes, sir.
Right, good. Any questions about that? No. So how do you diagnose actual hyperinflation? This is one way of one thing is that flattening of diaphragms, right? One thing is flattening of diaphragm, but for you to actually diagnose hyperinflation, you have to take a lateral film, right? Rather than a AP film. But in AP film, you can see more than 6 anterior ribs above the diaphragm, dome of diaphragm, or so you do check it at the mid-clavicular level, right? So make sure that you don't look anywhere else. At the mid-clavicular level, if you can see more than 6 ribs anteriorly or more than 10 ribs posteriorly, that's an evidence of hyperinflation. And horizontal downwards like that, right? But if ribs are horizontal, then again that's supportive of hyperinflation. And the lung fields will be hyperlucent. That means the bronchoscopal markers will be less prominent because alveoli get expanded and they press on the small bronchioles, so that the bronchoscopal markers will be less obvious, and heart shadow will also be less prominent compared to the normal lung, normal X-ray. It's so early. But if you want to objectively show there's hyperinflation, you have to take a lateral X-ray, right? In a lateral X-ray, you just draw a line between this end, the costophrenic angle, and the at the vertebral recess, right? And then you draw a line like that, right? Draw this, combine these 2 points, and then from here you measure the height of the diaphragm from that line, maximum height, right? Main යා කරලා dome එකේ diaphragm එකේ උස බලනවා කොච්චරද කියලා maximum උස. It should be more than 2.5 centimeters in the height, right? Less than 2.5 means there is flattening of the diaphragm. So that's the objective way of telling there is flattening of diaphragm. But in APV, we can subjectively say there is flattening of diaphragm. In a lateral view, again, retrosternal air space. That means they get the manubrium sterni there, right? From just below the manubrium sternal joint, right? To measure the distance between the posterior margin of the manubrium and the aortic arch. The aortic arch is there. So the A hariye is in aortic arch. The gap between the aortic arch and the manubrium sterni posterior surface should be less than 2.5 centimeters. If more than 2.5 centimeters, again that indicates hyperinflation, right? The other thing is, if you find air under the heart, usually you don't see air under the heart, cardiac shadow, right? Air under the cardiac shadow could be due to air under the diaphragm, or it could be due to hyperinflation, right? So these are the features that to say in X-ray there is hyperinflation, and characteristics they occur in asthma and bronchiolitis, right? Clear? Any questions? Okay. Shall we move on then? Harida? Harida, lama innada?
Yes, sir.
Shall we move on then?
Yes, sir.
So this is the X-ray from a 6-year-old child who was admitted with fever, cough, and shortness of breath. She initially responded for the antibiotics, but then started having high fever again. What is the diagnosis?
Lung abscess at the upper zone of the right lung.
Yeah, good. That's lung abscess, the right upper zone, right? So it will be better seen in this X-rays, right? You can see that. So there is a consolidation going on in the right upper lobe. Not now. See this in this X-ray, the entire right upper lobe is not involved, right? This is a bronchopneumonia, lobe pneumonia. Is this a lobe pneumonia or bronchopneumonia? This child is having? This is lobe pneumonia, right? It's a lobe pneumonia, but you can see the air above there, right? Apex air, that means the entire upper lobe is not involved, right? So parts of the upper lobe is involved, not entire upper lobe is involved. The right upper lobe pneumonia, and then there is this there's a cavity with a fluid level inside. Fluid is due to pus in the abscess, right? So this characteristic air fluid level, rounded shadow, point shadow, rounded shadow, right? And this one, there is no consolidation, but in this one, there's a consolidation. So this was secondary to a pneumonia, right? So if you see this, what is the most likely organism to cause it? Most likely organism, microorganism, you think of?
Staph aureus.
Staph aureus, Staph aureus. So you have to have anti-staphylococcal antibiotic if you see the lung abscess, right? And what's the other thing that can you get with staphylococcal infections? Apart from abscess, other lung problem, you can get bulla, right? Bulla formation and leading to pneumothorax. Again, if you get large cavities, lung cavities in the X-ray, then again you have to think of pneumatoceles. Pneumatoceles, those are caused by staph, right? So what will be the physical sign you'll see on general examination in this child? Most obvious physical sign. Question. What is the physical sign you would like to you would see during general examination of this child?
Clubbing.
Clubbing, good, clubbing, right? Because any suppurative lung condition like bronchiectasis or lung abscess, bronchiolitis obliterans also cause it, but any suppurative lung condition will cause clubbing. Will chronic CV asthma cause clubbing? Does chronic asthma cause clubbing? No, it doesn't cause clubbing, right? So it's mainly suppurative lung condition and bronchiolitis obliterans which can cause clubbing, right? So this is this peripheral sign would be clubbing, and there will be high fever spike going on. So in a child who has had pneumonia and responded to initial antibiotics, but then started having high fever spikes, consider this as a lung abscess. So can you drain this? Can you drain this lung abscess? What do you think?
Usually not drain.
You should not drain. This is all spontaneously after you treat the antibiotics, or they open into a bronchus and they drain spontaneously. If you drain cutaneously from skin, there can be a bronchocutaneous fistula, right? Which can be dangerous. So if you're draining, you might drain through the bronchoscopic approach rather than from outside. And what will be physical signs note during examination of the chest on auscultation? In child like lung abscess. Physical signs on auscultation. What will you notice? If you ausculted in this area, yeah, what is in this area? If you ausculted just above the air fluid level, you will have bronchial breathing, right? So bronchial breathing will be heard just at the level of air fluid interface, right? bronchial breathing. Yeah, what to say that post-acute suction, yes, if there's a cavity, if this abscess is opening into a bronchus, only you get that. Other physical signs are when you get this cavity opening into a bronchus. If the cavity is not opening into bronchus, you don't see all the other physical signs, but you will hear the air fluid level bronchial breathing. If the cavity is opening into the bronchus, then you will see what you call post-acute suction. That means when you cough, ask child to cough, they'll cough, 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 and whatever the material inside the lung abscess will be expelled out, right? And the cavity will be empty now. And with the next breath, when child breathes after the cough, air will fill the cavity, and then you will feel something like noise, right? Because the cavity gets filled up with that's what called post-acute suction. Empty cavity gets filled up after a bout of cough. And then you have other physical signs we call amphoric breathing. Amphoric breathing is when you auscultate over the area, if the cavity is opening into a bronchus, you feel like being blowing into a amphora. Amphora can recycle වයින්දා වාජන ගුරුලෙත් වගේ තියෙන්නේ. ඒක කටකට පිමිනිකුඩේ සද්ද එන්නේ. ඒ වගේ සද්දෙත් තමයි එතනින් එන්නේ. Amphoric breathing and there is whispering pectorality කියන එක. Right? Whispering pectorality, when you whisper, you can hear it sounds very clearly. So those are the physical signs you see on auscultation on the precordium. Right? Okay. This is the X-ray from a 6-month-old boy with a history of urinary tract infection. Right? What is the investigation? Micturating cysta urethrum. You can call it micturating void cysta urethrum. Give me a second. Hello. Hello. Yeah. බර කීයද? Huh? Right. Okay. We'll get a cannula. Ceftriaxone 500 milligrams once a day. Right. Ceftriaxone 500 milligrams once a day. Get a full blood count in a CRP. And then in a CRP, give 1 milligram of ondansetron IV stat. And then give cetron IV stat, and then start domperidone 3.5 ml TDS. Three point five ml. And then starter drip N/2 saline 1100 per 24 hours. Yeah. And the syrup Synco B 5 ml once a day. Right? Yeah. Okay. Thank you. Okay. Right. So this is a micturition cystourethrum. Some people call it void cystourethrum as well. So why do you say it's a MCUG? Why can't we treat IVU? Why? What? How can you say definitely it's a MCUG? Anybody?
So the catheter in.
Yeah, good. That's a catheter. You can see this is the catheter. So you don't put a catheter in IVU, right? And then the other thing, you see the generally you see ureters and
Kidneys and ureters.
yeah. So there are two radiological images done in renal tract. One is IVU and MCUG. IVUs nowadays we don't do much. right? It has been replaced by other better investigations, but occasionally we do IVUs. In IVUs, you take X-rays at control film and 0, 1, 5, 10, and 30, and in between if you indicated, right? So in IVU, you take X-rays after timing, certain time of injection of the dye, right? So there will be a clock. There will be a clock to indicate the time, or it will be written in the film 5 minutes, 10 minutes, or 30 minutes. Whereas MCUG, you take according to events, not the timing of injecting the dye. So what are the X-rays? How many X-rays you take in MCUG? How many X-rays you take routinely on MCUG? How many X-rays usually we take in MCUG? You have seen them? Minimum 3, but you can take 4. One thing is the control film. That is before injecting the dye. So look for any abnormalities in the skeletal system or any artifacts around the abdominal cavity which can interfere with interpretation. So you can get a control film, and then you get a full bladder film. You inject the dye, you know. But the area vomiting unlikely to be yeah. Contact kitchen and definitely. Right. But he has no symptom, ne? Yeah. Right. So you take a full bladder film. Full bladder film. After injecting the dye to look at the anatomy of the lung, the anatomy of the bladder, and then you take a film during passage of urine. You call it a micturating film. When child passes urine, take a film, and then after child passes, you take a film. You call it post-vital film. Right. That means so the 4 films. So if you want, you can omit the first investigation, first X-ray. But at least you take the full bladder film, micturating film, and the post-micturating film. Right? So out of the most important one is what? Out of the 4 X-rays, most important one is
Micturating film.
X-ray. Micturating film, yeah, micturating film. That's the one we're going to see the abnormalities commonly. But why you take a full bladder film, look at any bladder abnormalities and the peripheral abnormalities, filling defects like things. And then why do you take post-micturating film? Why do you take a post-micturating film?
To see
I mean, after passing urine.
residual volume.
Yeah, to detect residual urine in the bladder, right? After passing urine, how much of urine remaining in the bladder? Usually, there should not be any urine remaining in the bladder. So when you get the post-micturating volume urine, in which conditions? In which condition do you get post-micturatory volume in the bladder?
Neurogenic bladder?
Neurogenic bladder, yeah, but okay.
Obstructive conditions like PU.
PULs, obstructive condition, PUL, good. And then any other condition? Well, that's no. Then when there's a PUL, you need higher pressure in the bladder to evacuate. So you might not be able to empty entire contents of the bladder, like posterior urethral valve or urethral strictures. You can have post-vital volume. Any other condition? The most significant condition? PU reflux, right? It's like reflux. Because when PU reflux is there, urine goes back into the ureters, and then once the bladder relaxes, they come back to the bladder, right? So so that bladder will all be filled with some bladder urine in the bladder. So what is the significance of post-micturatory volume? What is the significance of having a post-micturatory volume?
Predisposed to infections.
Yeah, that due to stasis of urine in the bladder. Stasis of urine always predisposed to urinary tract infection. Right? So those are the things that you look in the MCUG, right? And this is a child with posturethral valve during a MCUG. What is the abnormal noted here? What are the complications that has happened due to the posturethral valve?
Hydronephrosis as
Not the mucosa prolapses to the bladder muscle wall outside, like cyst, right? It's called bladder diverticuli, right? Is indicate increased intravesical pressure, right? If you do ultrasound scan of the bladder, what will it say? What will happen to the bladder muscles if the posturethral valve?
Hypertrophy.
Hypertrophy, yeah, bladder will be hypertrophy. So we call it in the ultrasonically, you call it trabecular bladder. The bladder muscles are in like trabecular layers. So you will see like a trabecular bladder, right? So that the ultrasound appearance will be a trabecular bladder, right? And this appearance is called what? Kajubulang appearance, right? Kajubulang again, Kajugediya Bulamai again, Bulamai Kajugediya again, right? The typical Kajubulang appearance, right? This is due to what? This shadow is due to what? Kajugediya again.
Dilated posterior urethra.
Dilated, yeah, proximal urethra. Proximal urethra. That means the proximal part of the urethra. Usually at the junction of the opening of the seminal, vas deferens. Vas ejaculate duct join වෙනවද prostate කට ඒ join වෙන තැන තමයි ගොඩක් වෙලාවට valve එක තියෙන්නේ. It's just a mucosal fold, right? So mid part of the prostatic urethra you get it. So this is dilated posterior urethra. I mean the actual proximal urethra, vas urethra, and this is the bladder, right? And if you do ultrasound scan during antenatal period, you can see this appearance as well. ඒක මොනවද පේන්නේ මොනවද පේන්නේ මේකද මොකක්ද පේන්නේ දොරේ මොනවද පේන්නේ yeah, keyhole appearance, keyhole. So this characteristic keyhole sign you will see in the ultrasound scan if you do it during the antenatal period. So you should diagnose antenatally by ultrasound scan, and this characteristic radiology sign is keyhole sign. So what would be the prognosis for this child, 6-month-old baby? What will be the prognosis?
Poor prognosis.
What will be the outcome? What will be the outcome?
Poor prognosis can be.
Yeah, poor prognosis. What's the outcome? What will be our result? In result,
Child may go to CKD.
CKD.
Yeah, most likely go to CKD, right? Because any obstruction to the output, like obstruction to the bladder, anywhere that lead to dysplastic changes in the kidneys. It's progressive, right? So they will definitely one day go into end-stage renal disease. also an MCUG, right? Right. This is an MCUG. Give the complete diagnosis. Sonali, mic is with you. Sonali, can you give the complete diagnosis? Well, Ashini, didn't hear you answering any question today. What is the complete diagnosis here?
Bilateral vesico-ureteric reflux.
Bilateral circulatory reflux, and the grade? Is same on both sides?
No,
How to get it?
grade 4.
Grade 1 in the right.
Okay, right kidney. Right side, and then grade left side?
3.
It's grade 4. Right? So this is the gradient system, right? So if the reflux is limited to the ureters, which is in the previous one, right? So if the limited to the ureter, making only thing this in this one ureter is dilated a bit, but anyhow the reflux is limited to the ureter, right? So it is stage 1 because reflux limited to the ureter is stage 1. Reflux going up to the renal pelvis is stage 2, grade 2. Then mild dilatation of ureter and pelvic system is grade 3. Tortuous ureter with moderate dilatation of pelvic system. And in this one, the papillary impression is preserved. In grade 5, the papillary impression becomes lost. When renal papilla looks like that. Like that, no? Papillary impression is there. This is the renal pyramids, right? The papillary impression like that. So with increased pressure from this side, this becomes like that, clubbed, right? So the papillary impression will be lost. Then called stage 5. So in stage 4, there is cross dilatation, but the papillary impression will remain in the papillary impressions are there, right? So these pyramids are like that. So there is a papillary impression there. But those are lost and they become unipatrized. That is stage 5. So this is more like stage 4 in the stage 4 in the left side and stage 1 in the right side. Right. And this is again,
sir.
Yeah.
Sir, can we tell 2 different grades to 2 sides if
Yeah.
asked?
Yeah. Because it doesn't need to be always same. Right? Reflux can be differ from one side to the other side. You can be unilateral also. It can be on one side. It can be on both sides equal, or it can be unequal. Right? So this is the MCUG again. What is the most obvious renal abnormality here?
Sir, unilateral double.
Yeah, duplex system. Double ureters, but no single ureter actually. Single ureter, but duplex system here. The upper pole and lower pole are separate. Right? The drain beds will separate ureters and then join to form a single ureter. This is what we call a duplex system. Right? So upper pole of the kidney is drained by a separate ureter, lower pole by a separate ureter, and the two forms to form the other ureter. Sometimes these two ureters drain separately to the bladder. Unlike this one, so this upper moiety will come down here, this one come down, and then they open at different levels. And if you have that happening, usually there will be either obstruction of the ureteric opening in the bladder, or there will be a reflux, right? So that's that. If the two ureters are coming down, there is likely to be obstruction of the reflux in those ureters. And the main problem with this one is what? The system. You can have what you call yo-yo movements. Yo-yo කියන දකල්ද මෙහෙම සෙල්ලම් yo-yo කියලා. Right? So yo-yo එක වගේ yo-yo movement එකක් එන්න පුළුවන් මේකේ. In this part of the bladder, kidney. So the urine might just pass like that. මෙහෙම මාරුවේ තියෙන්න පුළුවන්. Without going down. Right? So that will cause stagnation of urine, and that will increase risk of urinary tract infection. Right? So duplex system also can lead to recurrent urinary tract infection because of stasis due to yo-yo movements of the දැන් මේකේ පේන්නේ මොකක්ද නෙමෙයි මේකේ රිෆ්ලක්ස් එකක් තිබිච්ච හින්දා. එතන තාම MCG එක පේන්නේ නැත්තම්. But if you suspect a duplex system, you have to go for a IVU. Right? What is this investigation? Give two reasons you answer also. What is this investigation?
IV user.
IVU, yeah, IV. Good. IVU, මොකද මේකේ එකයි IVU කියන්නේ යුන්නේද කිව්වේ?
The time is mentioned.
Yeah, මේ 10 minutes එක වැඩිලා නැහැ 10 minutes, right? 10 minutes there. එක පේන්නේ නැහැ 10 minutes. No, 1 minute, 0 minute මගේ 0 නේ. පේන්නේ 0 minutes. At the time of injection, okay. Other one is ඔයාගේ ඒ කවුරුහරි උත්තර දෙන්න එක ලයින් එක ගොඩක් තේමද එන්නේ. I can know.
Kidney schedules test.
Can't hear you. Line disturb වෙනවා. මොකද්ද?
The ureters are visible, sir, and they are not dilated.
Reflux එකක් නෑ.
Kidney shadows it will be dilated, sir.
Okay.
But these ureters are not dilated.
Okay.
Kidney shadows.
Once the bladder will be more like MCUG, bladder will be more rounded, right? Because full bladder film එකක් ගෙනින්න එකත් maturation එකක් නේද? Bladder will be more rounded. මේකේ IVU එකේ bladder එක ඒ ලොකු අර බෝලේ වගේ පේන්නේ නැහැ IVU එකේ. අනිත් තමයි ureters කෙලින් ඉරක් වගේ පේන්නේ කඩ කඩද පේන්නේ. කැඩි කැඩිනේ පේන්නේ. මේ හැර ureter පේන්නේත් නැහනේ. මේ පැත්ත ureter පේන්නේත් නැහැ. මේ ureter පේනවා. මේ තන්තවලින් කැඩෙනවනේ ureter එක. Right? In MCUG, the urine just goes up like that and demarcates the ureters just like a straight butter එකක් වගේ පේනවා. No interruption in the tubes, right? So it's a straight line without any breaks in it. But how does urine come down in normal people? In IVU, urine come down passively, no? In MCUG, it goes up, right? But in urine coming down, how does it come? Like peristaltic movements, right? So the peristaltic movements, so ureter go, some parts of the ureter will be in contraction, other parts will be urine passing. So you don't see a straight line like in MCUG, right? So there are areas which are not contained in dye. So the ureter will be marked by a line with interruptions in IVU. That's the peristalsis. In MCUG, if there's reflux, the ureters will be demarcated like a tube, right? අර මම ඉස්සෙල්ලා පැපිලා මෙන්න මේක හොඳට පේනවා. පැපිලා කියන මේ පැපිලොටින් ඉම්ප්‍රෙෂන්ස් කියන එක මෙහෙම. You see that? Papillary impression. What you call papillary impression. So if it is clubbing, make a right? It's like that now, no? Make a clubbing. Correct? That is IVU. So if you MCUG, ultrasound scan, and DMSA, DTP does not show any cause of abnormality, and you just think there can be some abnormality, you will go for IVU. Otherwise, generally we don't do IVUs, right? So it's only when all the other investigations are normal, but you strongly suspect some structural abnormality, then you can go for a IVU. One of the main concern about doing MCUGs, two main concerns about MCUG. What are the two main concerns about MCUGs? Can anybody think? One thing is you have to catheterize the child, right? For MCUG, you have to catheterize the child so that you can induce trauma and cause stricture same data, right? So that's one thing, is invasive procedure involving catheterization of the child. It's not easy in a small child, right? Especially uncircumcised child. And then other is that you are exposing the areas of gonads, not the genitalia, the gonads, right? Because ovaries and testes are directly exposed to the radiation. When you take chest X-ray or X-ray of skull or any other place, we tend to cover the genitalia with lead plates. Lead plates are placed over the genitalia, the ovaries and the testicle area, so that radiation won't reach the gonads. But you can't do this in doing MCUG, because if you do that, you will be obstructing the view of the where you want to look at as. So gonads will be directly exposed in an MCUG. So risk of mutations, right, radiation damage is high with the MCUG, right? So those are two things that mainly worry about when you're doing MCUGs, right? Okay. Any questions about MCUG and IVUs? Another problem is if you have an infection, underlying infection while doing MCUG, that can lead to pyelonephritis, right? Because if there's a reflux with a MCUG, you can introduce infection, and that can result in pyelonephritis, right? So you have to make sure that there's no infection for doing the MCUG. So recently taken during culture, about 5 days before the procedure should be negative before you embark on a MCUG, right? Okay. Any questions about renal investigations?
Sir,
Then
in IVU also there is radiation, no, sir? So
we also has radiation, yeah.
how?
That's why it has gone out of fashion nowadays. We don't do IVUs nowadays. As I said, we do only if you suspect abnormality which cannot be detected under investigations. IVUs have been replaced by MCUs. Have been replaced with DTPA scans, right? Hello? Okay. So most of the indications of IVU have been replaced by DTPA scan, right? DTPA scans, where you want to, mainly IVUs are done for obstruction, to look at a PUG obstruction or something like that. So those are now detected by doing a DTPA scan. So IVU also not done, not actually done. I haven't done IVU for a long time now, right, in my patients. Maybe about when I was registered. I can't remember doing any IVUs on a patient. Oh, wait, one or two. There are two patients I did as a consultant, right? So IVUs, early days, it was done in routine practice, but not nowadays, right? After DTPA scans came, IVU went out of fashion. Okay?
So how frequently is MCUG done, sir?
MCUG is done only when there is strong suspicion about either posterior urethral valve or vesicular reflux. So in a child during infancy, if you get a febrile UTI in a child during infancy, then you have to do MCUG, or if there's a suspicion of posterior urethral valve, antenatal scans, and then poor urinary stream, dribbling of urine, palpable bladder. So there's evidence, clinical evidence of posterior valve to confirm we do the MCUG. Right? So any febrile UTI during infancy is a definite indication. Go for a MCUG, right? Okay, move on then. Right. So we go for the bones and joints now. This is the X-ray from a 6-year-old boy who had painful limb. What is the diagnosis? The 5-year-old, ne? 5-year-old.
Slip femoral epiphysis.
No. The name.
Perthes disease.
Yes, Perthes disease, right? So when a child comes with painful limb, there are 3 diagnoses that are commonly encountered. Apart from other things like septic arthritis and rheumatic arthritis, rheumatoid arthritis, hemarthrosis, those can produce painful limb, but those have their own physical signs which point towards them. But you don't have those physical signs, you have to think of 3 conditions. One thing is transient tenosynovitis, then Perthes disease, and slip upper femoral epiphysis. Right? The most significant thing in the clinical history that to differentiate these 3 conditions is what? What is the most important feature in the history that would help to differentiate transient tenosynovitis, Perthes disease, and slip upper femoral epiphysis? Which history? Which component of the history?
Age.
Age. Good, very good. So how does age help you? How does the age help you? Perthes is rare before 4 years of age, right? So in children under 4 years of age, most likely to be a transient tenosynovitis, usually immunological reaction after respiratory tract infection. They get this painful limb, and then if you do ultrasound scan, there can be a small amount of fluid in the joint, but counts, yes, inflammatory markers are negative, and there's minimal restriction of movements, and this settles without any significant intervention with improve with simple analgesics. That is transient tenosynovitis. There's no lot of restriction of movements in transient tenosynovitis. Perthes disease commonly occur between 4 to 10 years of age, right? And slip upper femoral epiphysis occurs around 12 and above, adolescent period, and generally in obese children, right? So why do we get Perthes disease at this age? What's the reason? Underlying pathology behind in Perthes? What causes it? Sorry? What happens in the condition in Perthes disease?
Avascular necrosis of the capital femoral epiphysis.
Yeah, avascular necrosis of upper femoral epiphysis, right? So what happens? Yeah, how does it happen?
Interrupted blood supply.
How does it happen? Why that particular age group is vulnerable to have it? Why is it more common around 4 to 10 years of age?
Injury to ligamentum teres.
No, why? Why do you get?
Nutrient arteries are coming from the ligament through the ligamentum teres.
Okay.
At that age,
so there are blood vessels coming from retinacular arteries. Are there arteries from through the ligamentum teres, and then blood arteries coming from metaphysis, right? All contribute to the supply of head of the femur, right? So initially they come from mainly ligamentum teres, and then reticular vessels coming, and then metaphyseal arteries take over. So with time, the blood supply changes over from this ligamentum teres arteries to the metaphyseal arteries. So at a particular age, there is a overlap where one is taken over by the other. During that period, the other one is not properly formed, then there can be decreased blood supply to the femoral epiphysis, and that will cause ischemic necrosis. And what will be the features? You can see here: flattened, crumpled, fragmented upper femoral epiphysis, right? So, so the prognosis depends on how much of the femoral epiphysis is affected. If less than 50% of the epiphysis is affected, then prognosis is good, right? So the amount of femoral head is left, more than 50% is spared, then there's good prognosis. More than 50% involved in poor prognosis. And the features are that the head of the femur will be crumpled, flattened, and the margin of the acetabulum becomes sclerosed. Sclerosed, irregular acetabular fossa, right? Those are the features of further disease. Do you see this in acute stage? Changes? If child come with a painful limb for 4 days duration, do you do a chest X-ray of the hips? Do you straight away or not? You don't do X-rays immediately because it takes about 2 to 3 weeks to develop changes, right? Initially, there won't be any changes. So acute stage, you can't see any changes. Ultrasound may be helpful, but X-rays, plain X-rays are not helpful during acute stage. So do it sometime later. And if you're taking the X-ray, you take it. How to take the X-ray? The suspect pertussis disease, how to take the X-ray?
Frog leg position and anterior posterior.
Good. Frog leg lateral, and a AP film. And when you're taking the AP film, what precautions should we take? How to position the child?
Standing.
The child should be stand with toes directly facing forwards, not sideways, so that the head of the femur is not rotated sideways, right? So the toes should be facing directly forwards. That's the exercise you take, and management is mainly keeping the head of the femur within the acetabular cavity, right? After some time, we start repairing, and for repairing, it takes the template from the acetabular fossa. So head should be within the acetabular fossa to remold and form the normal head, right? If the head of the femur lies outside the acetabular fossa, during regeneration, it will not take the shape of the acetabular fossa. So it will be irregular, and that will cause osteoarthritic changes in the joint. And there will be persistent problems, short limb as well as painful hip joint, if you don't do that. So there are Perthes calipers, non-weight bearing calipers, right? Bed rest is the most important thing, and keeping the head of the femur within the acetabular cavity. Okay. What is this X-ray? So again, a child with painful hip. What is this one? What does this X-ray show?
Slipped femoral epiphysis.
Yeah, this is slipped upper femoral epiphysis. You can see here. This is the upper femoral epiphysis, and this one, the rest of the femurs gone away, right? So one thing you can do is you draw a line along the superior margin of the shaft of the neck, right? And then you draw a line like that. It should go through the acetabular fossa. You see, maybe the marginal line should go through the acetabular fossa. Here, to draw a line, it goes above the acetabular fossa, right? That's one thing you can do. Second thing is, you draw a line between these two edges of the head of femur, right? And then you draw a line, perpendicular line to that line, and then you draw the line parallel to the femur shaft, right? So the angle between this line and that line should be 0 to 30, right? 30 to 60 moderate. Sorry. 0 to 30 usually should be a line, right? Usually it should be same line. Make a kelimuti answer anode may angle 0 to 30 mild, 36 moderate, 69 severe. So degree of slip, right? The normal person, when you draw a line between this and the draw a line along with the midline again, making and the perpendicular line should be going through the shaft of the femur. Right? So with this line, this line, this is the upper end, this is the lower end, this line, and the perpendicular line like that, right? So it is going through the shaft of the femur, and this one here, the upper end and lower end, right? This line, the perpendicular line goes somewhere there. Okay. So we'll move on. This is skull X-ray of a child of 3 years. What is abnormality noted and what's the most what are the possible diagnoses?
Neuroblastoma.
What is the abnormality noted? What is the abnormality noted?
Cell demarcated lytic lesion.
Yeah, there are multiple lytic lesions, right? This one is there, right? So well demarcated, multiple lytic lesions are there, right? So there are osteolytic lesions. So possibilities are neuroblastoma or what else? Histiocytosis, Langerhans histiocytosis, or leukemia secondaries. And all those can cause lytic lesions in the brain of a child. Now, similar things can be seen in adults with multiple myeloma, but multiple myeloma is not common, not at all seen in children. So don't write multiple myeloma as a different diagnosis in a pediatric paper, right? So those are 3 things. Neuroblastoma. Most likely thing is Langerhans histiocytosis, but neuroblastoma and leukemia also possibility. What is this X-ray shows? What is the appearance of the skull? What do you call this appearance of the skull?
Copper beaten appearance.
Yeah, good. Copper beaten or silver beaten appearance, depending on whether copper or silver, right? That is because when you get a pot of copper or silver and you beat it with a club, so just tap on it, there will be indentations around the pot, right? So in something like that will happen in the skull, right? When you get this, what causes this? Sorry, any intracranial pressure, increase of intracranial pressure, hydrocephalus or tumor or anything like that. If anything that causes increased intracranial pressure, then due to the pressure, the gyri press on the inner table of the skull and erode the inner table of the skull. So at the areas of the gyri, the skull will be eroded, and in between gyri, skull will be normal. So the area here, now these is translucent areas. These less dense areas are the areas where there is gyri. In between there is the sulci. Sulci will be of normal density. Right? So it indicates raised intracranial pressure. The cause may be anything, but remember there is something called lacunar skull. Yeah, these changes are seen only in part of the lung, part of the skull, which can be normal. So if you're not sure, get a radiologist's opinion. This appearance is not always indicative of hydrocephalus. The lacunar skull is more large areas like that. especially posteriorly, localized areas of this copper beaten appearance, right? This is a child, X-ray from a child who complained of pain at the ankle joint, and they are swelling the ankle joint. What is the diagnosis?
Osteosarcoma.
Osteosarcoma.
It's osteosarcoma, right? So the characteristic feature is the sun ray speculations. ඉරෙන් රැස් විහිදෙනවා වගේ පේනවද මේක? ලස්සනට පේනවා මේක මේ. ඉරෙන් රැස් විහිදෙනවා වගේ. It's sort of called sun ray speculations. Codman triangle හොඳටම පේන්නේ නැහැ. Codman triangle හොඳටම පේන්නේ. Codman triangle is there actually between the periosteum and the bone formation, right? So this is osteosarcoma. So it's common to have children complaining of joint pains, right? Especially around 7 to 8 years, they complain of joint pains, and most of them have no problem, no abnormality. Even if you investigate or take X-rays, you can't find any abnormality, and they are generally called what?
Growing pains.
Growth pains. Yeah. They are generally labeled as growth pains. And if you clearly ask them, the pain is not in the joints actually. More in the calf and thighs, muscles actually. And it's thought to be due to the stretching of the bones during growth, cause it and more common after exercise. If the child plays a lot a particular day, their pain is more, right? But remember to exclude a bone tumor before diagnosing growth pains, right? Because bone tumors are more common during adolescence and childhood than older people. Because malignant bone tumors are more common in children, so don't miss a tumor, right? If you have a doubt, other thing is leukemia. Leukemia can cause bone pain and joint pains, right? So before you label a child having growth pains, make sure you exclude the leukemia and a bone tumor. So if it is doubtful, do the full blood count, a CRP and ESR blood picture to exclude the leukemia, and bone tumors for the ESR and CRP, and take X-ray. If you have a doubt, take X-ray and exclude it before confirming it's a growth pain. So just the growth pain, you can just go simple analgesics. We settle with simple analgesics, right? And this one again a pain, the child with the swelling at the knee joint. What is the diagnosis?
Ewing sarcoma.
Not Ewing, this is not Ewing's. Ewing's is onion peel appearance. This one has what? More like soap bubbles, right? Soap bubble appearance. What is this? This is osteoclastoma, right? Osteoclastoma, again more common around the joints. And this soap bubble appearance, right? Bambolo bolo, that is feature of osteoclastoma. Right. This is X-ray of from a 3-year-old boy. What is the diagnosis? It's a 6-year-old. X-ray from a 6-year-old boy. What is the diagnosis? Rickets, yeah, it's rickets. It's for rickets, right? So what are the features you see? There is get cupping, splaying, flaring, fraying, decreased bone density, pathological fractures with poor healing, right? And if there's healing rickets, you'll see a white line. You can see this cupping means, right? The end of the bone looks like a cup. Right? And then splaying means edges of the bone are pointing outwards like that. May I just going playing flares. Playing means that is spreading. Splaying means spreading. Flaring means it's just going outwards like that. Flaring. Splaying means spreading like that over outward spreading, right? And then fraying means the edge becomes moth-eaten appearance. මේ edge එක moth-eaten appearance එකක් එනවා. කාව කාලා වගේ වෙනවා. And the bone will be of less density, and you might see pathological fractures without evidence of callus formation. Right? So those are the features. And once you start treating rickets, you get a white line, sclerose line at the metaphysis. May I need white line? Make it me like the X-ray can see the arrow pointer. Right? So this white line, the sclerose line indicate treated rickets, right? So this cupping, splaying, flaring, fraying. Cupping is cup-like thing. Splaying means widening of the bone like that. Flaring means, splaying means the edges are getting outward. Flaring means expansion of the edge. Fraying means moth-eaten appearance, decreased bone density, and this white line you get when there is healing. Right? Actually, I got this specimen, nice specimen. It shows the part of the bone, right? Can you see this white line there, this bluish line? My line ke pain. What is that line? Can I see that? Yeah, that's the growth plate. Good. That's the growth plate, the growth cartilage. Take a minimum pain. When you take X-ray, you see this as a bone, this as the bone, this as the bone, this as a break. The makeup X-ray pain. So you take X-ray, you can see this part as the bone, this part as the bone, this part as the bone, right? And then when the bone is formed initially, it is initially formed from the primary ossific center, and it forms the diaphysis, so main shaft of the bone, right? So when the child is born, there is a shaft of bone which is formed by the primary ossific center, which is called the diaphysis. And then after birth, this growth plate produce bone, osteoid material, and that is mineralized to form the bone. Right? So in the growth plate, the osteoid is produced. Osteoid is osteoblasts are there. Osteoblasts will produce osteoid. Osteoid will be mineralized to form the bone. And what is that bone? Bone is called what? Diaphysis is the initial bone formed by the primary ossific center. The bone formed by the growth plate is called which one? Diaphysis and this one? Good. So this diaphysis, so along with the diaphysis, you get the metaphysis, and then you get the growth plate, and within the growth cartilage, you get developed. What are these then?
Epiphysis.
Yeah, secondary epiphyseal centers, right? So they start growing separately on the growth plate, right? And then they'll grow. Ultimately, they will fuse with the metaphysis, and then the growth plate will disappear. So with that, the bone growth will cease. That's how it happens, right? So then you don't see a gap between the metaphysis and epiphysis. That's how the final bone formation takes place. I mean, rickets, what's happened? You might not see secondary epiphysis center that much, and then both plate will produce osteoid, but it not be mineralized, right? Because there's no calcium phosphate to mineralize the osteoid. It will remain there, and it will form a bulge, right? Because osteoclast is the one that we go and remold the bone, the shape, all the processes and the things are produced by the osteoclast. It will remold the bone formed by the osteoblast, right? But osteoclast can't do anything with the osteoid material. So there will be bulge of osteoid at the end of bones. So bulging of these ends of the bone due to the accumulation of osteoid which are not mineralized, and that form pressure on the metaphysis. But had an osteoid again apply pressure on the metaphysis, so metaphysis becomes cup shape. May pressure again the metaphysis. and got the pressure, again the bone ends. The end of the bones get spread outwards. That's what we call flaring. And this end becomes more widened and cause pain. And because this osteoclastic activity of the metaphysis, the edge becomes irregular and ragged, we call the fray. Right? So that's how we explain the features you get in rickets. Clear, Mother? Understood? Clear? Any questions? Any questions about that? Did you understand what happened in rickets? Hello? All there? Is it clear? So that's what happened in rickets, right? So the mineralization does not take place, right? So the remolding does not take place. And then there will be swelling at the edges. And important thing is that rickets is a disease of growing children. Severely malnourished child might not develop rickets, right? So in a severely malnourished child, you will not see evidence of rickets, and it will be evident only when the child is nutritionally rehabilitated. With the rehabilitation, child will develop all the vitamin deficiencies and mineral deficiencies. So in a child who is having vitamin D deficiency or calcium deficiency with malnutrition, will start to develop rickets only when you rehabilitating child nutritionally, right? So don't expect to find rickets in a malnourished child. Okay. I think that's all we have. Yeah, one more X-ray. This is the X-ray of a 4-year-old boy. What is the bone age of this child? How to calculate the bone age? What do you use to calculate the bone age? Now you have 3 ages. For a child, you got 3 ages. One thing is the chronological age, which you calculate from the date of birth. Then you have the height age, which you calculate according to the child's height. That means height of the child, and you plot it on a growth chart where it forms and 50th centile, at which 50th centile corresponding age, that heights 50th centile age is what we call height age. Babage usa 50th centile එකේ තියෙන age එක තමයි height age එක. Right? So I say if the child's height is 100 centimeters, right? 50th centile 100 centimeters in at least at 4 years now, then height age is 4 years, not 5 years. Then 4 years වලදී නම් height එක 50th centile එක 100 එන්නේ. If this child's height is 100, then that is its height age. Height age will be 4 then. So its chronological age is 5. Bone age is you calculate according to the bone, right? So you take 2 things. One thing is the appearance of epiphysis, secondary centers, right? Secondary centers and fusion of epiphysis, appearance and fusion, right? So in a young child, you do a X-ray of the wrist. Up to about 1 year, you can do that. After that, you are taking entire half of the rim. Because අතේ තියෙන්නේ මුලින්ම කක්කෙනෙක් ආසකයේද. First epiphysis is formed at 3 months, that is capitate. Then 6 months hamate. So 3 months you will have one like that. This is capitate and hamate, capitate, and then you get hamate, right? At 6 months. So at 6 months you will have 2, right? And then all the others take about 4 years to develop. Third, 4 years already. So between 6 years, 6 months and 4 years, nothing happens in the carpal bones, right? So up to 6 months, like can do the hand, but after that, After 4 months, again, 4 years, you can use the hand. But between 6 months and 4 years, you have to go for the entire upper limb, right? You go for the appearance of epiphysis of the humerus, the radius, ulna, right? So in this child, you got 2 carpal bones, so it is more than 6 months, right? And then the radius appears around 1 to 2 years, but none of them are there, right? So this child's bone age is around 2 years, right? Less than 4 years, right? 2 years. So you got 2 carpal bones and radius, distal radius. So its bone age is 2 years. So child is 4 years. So child chronological age is 4 years, bone age is 2 years. So the gap between the chronological age and bone age is 2 years. So what are the conditions that cause bone age more than 2 years lagging? There are two major conditions. What are the conditions? Significant bone age delay.
Constitutional delay of
No, so any insult that cause growth retardation can cause delayed bone age, like chronic infections, chronic malnutrition, constitutional delay in growth and puberty, right? Those all can cause delayed bone age, but delayed bone age more than 2 years is characteristically of growth hormone deficiency and hypothyroidism, right? So in hypothyroidism and growth hormone deficiency, there is bone age delaying more than 2 years, right? But some skeletal dysplasias, some skeletal disorders can cause same thing, but these are the 2 endocrine conditions that cause significant bone age delay, right? I think that's all we have. Now, what is this condition? This is a newborn baby who did not like to be handled. What is the diagnosis? This baby did not. Yeah. Osteogenesis imperfecta. Right? So what you see, bones are almost like soft tissues, hardly any mineralization of bones. There's a fracture here, and fracture there, which has not healed with pseudo-joint axilla, and then bent bones, right? Right. So there is problem with collagen formation here. So bones don't get mineralized, and they get easily fractured, and they don't like to be handled. So because handling become painful. So there are 3 conditions that cause handling painful. One thing is this condition, osteogenesis imperfecta. Second one is septic arthritis. Third one is congenital syphilis. Right. So those are things to consider, because generally newborn babies stop crying when you cuddle them. Right. But in these 3 conditions, they will start to cry when you cuddle them. Right. So these are things to consider. What is the treatment of this condition? Alendronide that prevent osteoclastic resorption, right? That's the treatment that you give for these children, right? Right. That's it. So any questions you want to ask? That's the end of this class.
So can you please explain about the bone age?
Sorry?
Can you please explain about the bone age calculation?
Right, okay. Right now you use either appearance of the epiphyseal centers like this, or fusion of epiphyseal centers, right? That are 2 things that we consider. So for that you should know around what age these appear, right? Now first bone to appear in the carpal bones is capitate. Second bone is hamate. Capitate is at 3 years. Hamate is at 6 years, right? And then other bones start to appear around 4 years of age. Triquetrum and trapezius, they start to appear around 4 years of age. Fusiform at 12 years. And distal end of radius is around 1 year, 1 to 2 years. It has appeared, but no other bones have appeared. So the child is having child is only 4 years, got only these two, and this one. This is 1 to 2 years. So bone age is around between 6 months, 2 years, around 2 years bone age. I know this is the one that appears last appeared one. So this appears around 2 years, right? Others have not appeared yet. So bone age is 2 years. Falling in a right? So that indicates significant bone delay. So if one carpal bone was, another carpal bone was there, it will become 4 years. Right? So you can't give exact age, but you can give a range. You can give a maximum upper limit of the bone age, right? So that's how we calculate it. Okay. Make a so maybe it's not even 6 months radically 6 months and 2 years. Make a 2 years, right? Okay. Right. Any other questions?
Sir, can you explain rickets using this specimen again?
Okay. Right. Now this is the bone, right? So at birth you get diaphysis. Diaphysis is the primary bone. When you're born, you get the diaphysis. So what the bone formed from the primary ossific center, right? And then at the end of the diaphysis, you get what we call the growth plate, which is the cartilage, which is not seen in the X-ray, right? So the growth plate is there. The growth plate produces the osteoblast produce osteoid material. Osteoid will be mineralized by deposition of calcium phosphate into bone. Right? So from here, osteoid is produced and osteoid is mineralized to form bone. That is the metaphysis, right? And then in here they appear the secondary ossific centers, right? Secondary ossific centers, and then they grow towards this way, towards the growth plate. Metaphysis goes towards the growth plate. Ultimately, metaphysis and epiphysis fuse together, and that ceases the bone growth. That's a normal bone growth, right? So there are 3 parts: the diaphysis, the metaphysis, and the epiphysis. Right. So what happens in rickets is that the growth plate start producing osteoid material, osteoblastic action. They produce osteoid, but it is not been mineralized. So you get accumulation of osteoid here without mineralization. The osteoclast can't resorb or remold osteoid. It can only remold the form bone, osteoclast. So that's how they remold and produce the final shape of the bone is produced by osteoclastic action, right? Here, because osteoid cannot be modified by osteoclast, they get accumulated in the end of the bone. So you get bulges of at the end of bone, right? At the joints, you get bulging of joints because of this collection of osteoid material. And because of the osteoid get collected here, it apply pressure on the metaphysis, right? So metaphysis get pushed backward like that. So you get a cup-like thing. So get pushed to pressure of the osteoid collection. So you get a cupping of that. And then because the pressure of the osteoid, you get these ends of the bone. End of the bones get spread out. You call it splaying, right? And get this the entire thing get widen, it's splaying, right? Make a wide whenever edges at the tenor splaying, and then whatever the metaphysis that is formed get resolved by increased osteoclastic action because of increased parathyroid hormone. So the edge of the metaphysis become ragged, irregular edge. What do you call fray? So 3 physical signs, you see extra radiological signs, get cupping because of pressure on the metaphysis by osteoid, so it convex like that, and edges get pushed outwards. The entire lower part of the bone get expanded like that, and then edge of the bone metaphysis become ragged, moth-eaten appearance because of osteoclastic action, right? That is it. Okay.
Okay, sir. Thank you, sir.
Any other questions? Okay. Right. Then we stop here, right? Okay.
Thank you very much, sir.
Thank you, sir.
Take care. Bye.
Thank
Thank
you,
you,
sir.
sir.
Thank you, sir.
Thank you, sir.